Welcome to this talk in which I'm going to take you through the recent advances in management of resistant hypertension. Resistant hypertension is a big entity in terms that a lot of patients get uncontrolled blood pressure despite adding multiple drugs. So when we approach a patient whose blood pressure is not controlled despite 3-drug regimen, which includes a diuretic, ideally substituting optimally dosed chlorthalidone or indapamide, which are called as thiazide-like diuretics, and if still the target is not achieved, the first choice is to add spironolactone or eplerenone as an additive MRA. Once that is also not adequate enough to control blood pressure, next stop can be to look at the heart rate, and still if the heart rate is more than 70 beats per minute, you can add a beta blocker, either metoprolol, bisoprolol, carvedilol or labetalol, and if beta blockers are contraindicated, then maybe a weekly patch of clonidine or once daily diltiazem can be suggested as per the ACC guidelines. Adding hydralazine 25 mg 3 times a day and up titrating to the maximal tolerated dose, especially in patients with reduced ejection fraction in a background of nitrates 30 mg, is recommended based on AHEF trial, which showed that the heart failure hospitalization and event rates were reduced in African black population. If still it's not the case, then adding minoxidil can be the next choice. MRAs have been extensively studied in resistant hypertension and they should be tried first, starting with the spironolactone of 12.5 mg and titrating up to 25-50 to 50 milligrams once a day. However, risk of breast tenderness and gynecomastia with erectile dysfunction remains at a high dose. Eplerenone is less potent but is also less likely to cause adverse events like spironolactone. One needs to check potassium levels every 4 weeks and 2 weeks if the patient has higher potassium at baseline and is a known case of CKD. The recent advances that include our dual endothelin 1 blockade with aprocitentan in resistant hypertension. This is the novel therapy which has now come in the market. It's not yet available in India. So today I'm going to take you through the new drugs on horizon, renal denervation therapy and electrical stimulation of carotid baroreceptors as the currently experimental and beyond conventional therapies that can be used. The new drug class include 3 groups of drugs. One is angiotensin antisense oligonucleotides, then endothelin antagonist and aldosterone synthase inhibitors. Zilebesiran, which is an investigational interference RNA therapeutic agent which is linked to the N-acetyl galactosamine ligand that binds with high affinity to the hepatic Asialoglycoprotein receptors, is designed to achieve specific reduction in these mRNA levels by reducing the production of angiotensinogen. Hence, the RAS inhibition with this approach may theoretically limit compensatory angiotensin activation with ACE or ARB. Extrahepatic angiotensin expression may be preserved, thus limiting of the target of the kidney and other tissues. So as we know, basically renin, ACE are the targets that have been used. Direct renin inhibitors, though were aliskiren-like molecules, were tried previously, but because of the negative data of higher stroke rates in atmosphere trial, aliskiren was withdrawn and is not currently used. However, inhibition of angiotensin mRNA based on the RNA-based therapies to targets which include the RNA interference such as Zilebesiran or antisense oligonucleotides such as Ionis AGL1, which is still investigational, are the 2 choices that are targeting mRNA degradation as the therapy, which causes reduction in blood pressure by inhibiting the vasoconstriction, inflammation, fibrosis, cardiac modeling, sympathetic activation or vasopressin secretion, or sodium retention, oxidative stress and aldosterone production as the RAS pathway inhibition. Mechanism of Zilebesiran, as I mentioned, is a silencer RNA therapeutic agent which has GalNAc associated with AGT silencer RNA. It binds to the hepatic ASGPR, which with endozyme which gets into the released into the binds to the RISC, and this RICS inhibition with the has the hybridization guide strand to the AGT mRNA, and this along with the cleavage and degradation of AGT mRNA causes inhibition of angiotensinogen and angiotensin, hence reduction in blood pressure. Single dose zilebesiran of 800 mg sub-Q has been studied and published in NEJM in 2023, which shows over 24 weeks, which is 6 months, the blood pressure of 800 milligrams of zilebesiran single dose led to a significant reduction from the baseline levels of the patients who presented at 24 weeks with the levels of angiotensinogen. If you look at both the serum angiotensinogen and ambulatory blood pressure, there was no drug-related hypotension. However, question about hypotension remain whether they will have occur in patients with volume depletion, hemorrhage, infection, myocardial injury, anaphylaxis, etc. The JAMA published this paper with Beckeris et al. In KARDIA 1 randomized controlled trial in 2024, where 394 patients randomized and through 377 analyzed to 150 milligram of Zilebesiran sub-Q given every 6 months versus 300 milligram versus 600 milligram as compared to placebo. If you look at the 3 months, the Zilebesiran 150 milligram led 7 millimeter reduction, 310 millimeter, 608 millimeter in placebo had rise in blood pressure. This significant difference with Zilebesiran 150 and 300 shows it as a potential drug that can be given every 3 to 6 months, significantly reducing 24-hour ambulatory systolic blood pressure at 3 months. So, in patients in KARDIA 2 were enrolled where they look at the randomization of a run-on period of 4,481 patients. This was published again in 2024 at the ACC annual meeting, where they randomized to the placebo group in patients already on indapamide or amlodipine or olmesartan, and they compared the 6-month follow-up in these patients. If you look at the reduction in blood pressure compared to indapamide top-up therapy in compared to placebo, the reduction in the least square mean and the least square difference was almost 12 millimeters of mercury versus 9.7 with amlodipine and only 4 with olmesartan. And hence, it's proposed that probably it works best with diuretics. Ferebastat is another oral brain aminopeptide inhibitor, which is angiotensin 3 as an effective peptide for brain fibroblast and orally active brain penetrating prodrug of EC33. The possible mechanism include reduction in vasopressin release, sympathetic nerve activity, and increase in baroreceptor activity. Ferebastat in hypertensive overweight individuals, look at the change in the aortic blood pressure from baseline to 8 week was looked at in Ferebastat a 500 milligram BD, and as you can see, systolic and diastolic both pressures were reduced significantly, almost in the range of 10 millimeters systolic and almost similar range in the diastolic blood pressure. Baxdrostat is another treatment which is aldosterone synthetase inhibitor treatment targeting for suppression of hormone synthesis rather than blocking the mineralocorticoid receptor. Preclinical phase 1 studies have shown that Baxdrostat has highly selective aldosterone synthase inhibition of 100:1 as compared to enzyme cortical synthase. If you look at the blood pressure reduction, change in the systolic blood pressure can go as much as in patients with LL squared means of almost change in systolics of 20 millimeters with 2 milligrams and 15 millimeters nearly with diastolic blood pressure. The placebo also had some lowering, and hence the effect difference rises with the potassium levels of 6 or greater in 2 patients, but these does not recur after withdrawal or initiation of the drug. The other therapies that have been looked at include Simplicity 3 trial of renal denervation, which was published in 2014. There is no significant benefit observed at 6 months. There was benefit seen at long-term follow-up only from 12 to 36 months after the procedure. So this is the first randomized sham control, which means the patients who were not getting renal denervation also underwent a procedure just for the placebo effect of the same, and 2:1 ratio was aligned in this, and the average reduction at 6 months was 14 versus 11 in the renal denervation versus sham group, with no significant difference in 24-hour ABPM at 6 months. However, at 12 months there was a significant difference. The other therapies include baroreceptor stimulation for resistant hypertension. This is very much like baroreceptor for heart failure, except that the stimulation rates are different, where the vagal nerve is dissected and is connected to the stimulator or program stimulator, which activates the same. The RAINMARK trial in renal artery stenting have been EMMA, and they have also looked at the Dutch, STAR, Astral, Coral, and ACC recommendation. The rational approach, hence, in patients with the resistant hypertension includes these therapies, but for the word of caution for renal artery stenosis, that there is no difference in primary or composite endpoint of any of the events, or even blood pressure reduction is not recommended in a unilateral asymptomatic renal artery stenosis. The summary of rational approach enhances importance of resistant hypertension is associated with adverse outcome. You should exclude non-adherence and white coat hypertension. Triple regimen with ACE or ARB or long-acting CCB and diuretic should be first used, and if still you have used chlorthalidone or indapamide, which is preferred over hydrochlorothiazide, then a vasodilatory beta blocker, an MRA like spironolactone and eplerenone, and a peripheral alpha blocker if selected beta blocker does not have an alpha blockade properties can be added. Other vasodilating agents like hydralazine, minoxidil, or centrally acting drugs like clonidine can be considered prior to subjecting them to these novel therapies that are emerging. Thank you very much. Looking forward to connect with you for further learning sessions across. Take care. Bye-bye.